Hi, everyone. Today I have a guest who's not only a friend and a colleague that I've known for years, he was one of our first podcast guests back in, I think, about 2010, back when we were just starting this. So I remember Alan standing with you in the hallway, I think is when we did it. But I remember meeting you way back then. So we've both come a long way, baby, since then in the last 15 years. So Alan, if you could help our guests get to know you a little bit about like what you're doing these days and kind of what your responsibility is, and we can just dive into the topic today.
Yeah, sure, you bet. And I looked a lot younger back then, I think, when we first met. Happy to be here again, Stuart. Alan Shoebridge. I'm Associate Vice President of National Communication at Providence. We're a seven-state healthcare system, more than 51 hospitals. And I've really worked my entire career in either healthcare marketing or communication. And today I'm firmly kind of on the communication side, overseeing like our PR, crisis communications, and thought leadership for our organization.
Great, awesome. And Alan has been, I guess you're a president of Shishmid and been around and done a lot of exciting things. And I think your position at Providence, like you're with the leading system, so you get to see and be a part of some big things happening in healthcare. And so I hope to talk about some of that today, actually.
Yeah.
So Alan and I were speaking recently. I don't know about something, and we came up with the idea of doing this podcast. And the one of the things that Alan brought up, which I thought was really intriguing, is just how terms that really matter a lot in healthcare can be misunderstood. And even people in the business sometimes don't really fully know what they mean. And they can have some big ramifications. And I thought when Alan suggested that as a topic, I thought that's great. And just truth be known, I literally about, I don't know, 6 weeks ago just did a revised training for a team on healthcare terminology. And went through like all the major stuff just because, we always have new people coming in. And we do trainings probably every 18 months on these kinds of topics because it's really easy for people to get lost. But the ones you brought up, I thought were really intriguing. So we're not going to talk about PPOs versus HMOs today. We're going to talk about some terms that are even sound even more basic, but have huge ramifications. So before we dive into the specifics here, Alan, what made you think this was an important topic? I'd love to hear your point of view.
Yeah, well, you kind of referenced to how long ago we met, but as people come into the industry, it's not an easy industry to figure out. I mean, there's a lot of terminology that's just complicated that you've never heard before. I mean, most of us have used healthcare, but we don't really know what goes on behind the scenes. But once you join an organization, either you're working directly for a healthcare organization or you're working for a partner that might support a healthcare organization, you're just going to get a lot of terminology thrown at you and concepts that just don't make any sense. And so, how do you navigate that? And so, a few years ago, I just thought about, how can we help people navigate that better and, cut the learning time down for them. And also maybe, even avoid having to ask, embarrassing questions, things like that, but just kind of do some help along that journey for people because, again, our industry is not easy to understand if you haven't had any background in it. So that was kind of the genesis for the idea of really helping people with some of this terminology.
Yeah, and I think it's really easy to just sort of try to fake it till you make it, but not understand the nuances of
Yeah.
it. And the way it's used is not easy to look up online. And there, it is funny today with things like ChatGPT and Perplexity. It's a little easier to find what you want without hours of researching. But again, it's like sometimes I think people think they know something they don't really understand. So let's start off with one of the a concept that you personally didn't understand at first that's really important. You had one in mind you wanted to talk about.
Yeah, and actually, I'm kind of embarrassed. I don't think I really understood this for maybe five years or more. Like I kind of heard it discussed, and then it's become something that's more prevalent recently. But it's the length of stay, and it's also a term that's you often hear it just said LOS, and at first I was like, what in the world is LOS? And it's length of stay. That means how long an inpatient is in the hospital. So when someone actually gets taken in as an inpatient, they get admitted to the hospital, how long are they there? And what you'll hear about in healthcare is really wanting to reduce the length of stay. So getting patients out of the hospital as soon as we can. But that's not necessarily what the average person would think, especially when it comes to something like marketing, right? Well, you have a patient in the hospital, of course, you want their stay to be long because that's how you make your money. That's what I hear. That's what I'll hear on like a social media post or something. And the truth is exactly the opposite. We want to get people out of the hospital as soon as safely possible. It's better for them, but it also has benefits to our throughput, our financial situation. So the average hospital is actually working to reduce length of stay. But I think, again, when I started out in healthcare, as a marketer, I would have just thought, well, of course, you get people in the hospital, like, you want them to not be there longer than are necessary, but isn't there some value in having a longer length of stay? And there's not. It's actually a short length of stay. So I
How is
think that,
that?
yeah.
Yeah, I have a quick question on that. Has that changed since you've been in healthcare? Like, has it always been that way from your point of view, or how's things evolved?
No, I don't think it's ever changed, but I think what's caused it to get more, urgency now is that we just have such backlogs. Especially as the pandemic hit, there was just more people who needed to be, admitted to the hospital that we could admit. And when you have a shortage that's become really prevalent over the last 5 years, a shortage of doctors and nurses and others, like you want to be able to admit people in the hospital. Sometimes it's very complicated. And I think also something around this that people don't understand is a lot of times we're able to discharge someone, but they don't have anywhere to go. They don't necessarily need to be in the hospital, but maybe they don't have the right level of care that they do need. They need to get into like a assisted nursing facility or something, but there's nowhere in the community to take them. Those are all full. So our length of stay gets longer, and we can't admit people into the hospital. Sometimes they really need, elective surgeries and other things that might require some sort of hospital stay. It makes it harder to admit them if we can't discharge other people. So I think what's really caused it to have, I don't think the concept has changed since I entered the industry, but I think the urgency has, just because there's such a backlog of people who really do need procedures. And we saw that get heightened a lot during the pandemic, and really it's been a problem ever since.
Yeah, I think access is such a huge issue. It's funny when we're talking about this, I'm thinking back to when we had kids. Our kids are now early 20s and mid 20s, so it's been a while. But back then, it was shocking. Even then, we were talking about, wait, you're only in for that long, and they want you out that quickly because it was perceived, I think, by that way back then, if you were a patient, as they're taking better care of you by making sure you're there, versus nope, off you go. And
Yeah,
so that's important. So let's
yeah,
let's
yeah,
talk let's talk about something else, which
yeah.
is the payer mix.
Mhm.
And again, there's huge ramifications in payer mix. And I'd love you to talk about, that. How does that?
Yeah. Yeah, well, I think again, for people who are new or might be just entering the industry, they don't even know what it means. They hear paramedics, like they have no idea what that means. And that means, that basically you have kind of three populations of patients, and maybe you could say four, but you have those who are getting really reimbursed by Medicaid. Those are people who are on Medicaid programs in a various state. And different states have different terms for that. But that's at a certain level. And then you have Medicare, have all the people who are on Medicare plans, mostly over 65, but there's others. And then you have the commercially insured people who, they have a health plan, health insurance paid for by their employer. And you really want a good mix of all those, because if you'll talk to the average, hospital chief executive, they'll tell you, you're really getting reimbursed for your cost at like, 30 cents for Medicaid and 60 cents for Medicare. And then you're reimbursed above that to balance it all out. So the thing is, if you have too much Medicaid and Medicare and not enough commercial, you're basically losing money on all your services. And so that mix really hurts your balance sheet at the end of the day. And that's, I think, why you see so many things where you'll have hospitals and health systems negotiating with insurers to make sure the payments are right, because that mix really matters in terms of your financial performance. But I think, again, as a concept, like the average person on the street doesn't really think about that very much. They don't understand how that mix could result in some really challenging finances for a hospital.
Yeah, it's really important. Like, for example, Medicaid, where, different hospitals view their mission and their community differently. And so some are, really become essentially Medicaid hospitals. And oftentimes they want to get into more of the private pay or commercial insurance, to help, with
Balance.
with the finances. But then it's a different marketplace too. So this is good. Each of these topics we could spend a whole discussion on, of like, if you're going after commercial pay patients, their expectation levels are going to be probably different. I'll just do a quick aside. I worked with, this is something I've talked about a few times before, but years ago, we were working with a famous charity hospital in downtown LA, and that was a big part of their mission. They were largely, poor and Medicaid or no pay, and they wanted to do elective spine surgery. And one of the things I talked to them about before is we can go after that. We can absolutely drive inquiries, but you need to make sure you understand that. Sorry, that just distracted me. I just got
Oh,
something else. Let's start that over part, and we'll
okay.
edit that. So one thing I've talked a little bit about before is in the past, I worked with a hospital in Los Angeles that worked for the poor and Medicaid and no insurance at all. And they wanted to go after elective spine surgery. And I cautioned them, you need to make sure you have a patient experience that's appropriate for that because it's just a different thing. And they didn't believe me, so we didn't do the training like we were going to for the phone calls. And the first day we generated a lead and it went all the way to the CEO. So like this idea of a payer mix has such an important strategic implications for a hospital or health system, but it also has operationally, like how do you, handle that? I don't know if
Yeah.
you have any comments on that before we move on to the next topic.
Yeah, no, but I think you're exactly right. And different communities, I think when I look at what we do at Providence, like we want to reflect the community we serve. And, where I'm based in Portland, Oregon, you have all members of those types of communities. You have the Medicaid patients, Medicare, you have commercially insured. So, you do want to have an experience that resonates for all of them. But I think the key is just for people to know is like, again, why that matters is if one gets out of balance, it's a financial implication, but I think you're bringing up something else. It's also like, what's the experience for the patients? And do you have something that really can reflect the community you serve? And that's super important. And it's just a challenge I think that they're always looking at in the industry.
Yeah, and I think it's come a long way because, ethically,
Yeah,
I think most people want to treat everybody the same and fairly, right? So that's come a long way, but it does matter. It has huge implications on profitability as well as sustainability, I guess, even if you're a nonprofit and more than profit.
absolutely.
So on that note, the concept of no margin, no mission. This is one that you don't hear very often unless you're more of an insider, I think. But like, let's talk about the ramifications there.
Yeah, that was the term I heard early on. I was kind of, what exactly does that mean? But really, for most nonprofit healthcare systems, in the good times, they were making a margin that's somewhere between 1% and 3%, right? But, during the pandemic, that got turned sort of upside down. And so, those hospitals that were kind of subsisting on 1% to 3%, margins, all of a sudden they're losing money. And the thing is, if you cannot at least get that 1% margin, profit margin into, your operations, you can't last very long. You have cash reserves and anything you can dip into. But the idea was, again, we have to make somewhat of a margin on our services overall, or otherwise we just can't serve the community. You can't lose money year after year after year and be profitable. That's why we've seen so many hospitals, unfortunately close in rural areas, other things, because they can't meet that margin. And if you don't make a margin, you can't meet your mission of service. And where I think this gets a little bit misunderstood by, say, the public, a lot of people just kind of figure all hospitals, they don't really need to make money. Like they don't really understand the nuances of not-for-profit versus for-profit. A lot of people just think hospitals kind of exist as like a charity in a way. The understanding of financing just isn't very visible to people, and I understand that. But it's interesting when I'll read comments about hospitals on social media or something, and so a lot of people assume they can lose money and keep operating. Well, you can only do that for so long, and that's why we've seen hospitals close. So that's the idea. If you're not making at least a modest margin, you're not going to be able to offer services to the community.
Right. And that's, we talked about this during COVID too, about the misperception that these hospitals are gouging patients and making all this money when so many of them were losing money, like kind of breathtaking rates. And so I think it's a challenge. As a communications officer, that's without going too deep into this, but is that something that you can have an impact on, or we just sort of hope people get the message? How does that work?
Yeah, I think we're always trying to educate about it. We talk about every year, Providence puts out a community benefit report where we sort of explain it and talk about, how we give back and sort of, costs that we assume and just the overall financial situation, what we're trying to do. So I think, whenever we put out we do quarterly financial reports, we try to explain that. But again, it's complicated. I just think, that's one of the things about healthcare, at least, we overuse the cliche, healthcare is hard a lot, but it really is. And the financing piece is super complicated. So we try to message it, internally and external where we can. But I just think one of the challenges, and you and I've talked about this for years, the average person is not thinking about hospital financing until something bad happens, until
Yeah.
there's a real negative outcome, like a hospital might have to close, and then all of a sudden people, they're gonna think about it. But how the financing works for hospitals is just not something on people's mind most of the time, and I understand why.
Yeah, for sure. And then even, short of closing the hospital, they may stop taking OB patients, right? So
Yep,
that's a huge ramification if you're in a rural area, for example. So it's even short of
exactly.
closing, it's a big deal.
Yep.
So I know you published a list recently of 25 hospital terms that every healthcare marketer and communicator should know. And I love, by the way, you're going to talk about thought leadership a little bit later. And I love how you do that as well. But let's talk about some of those terms from your list. I'd love you to talk about those as well.
Yeah, these are just some other terms again that I saw, and I kind of think, I don't know who would understand this. And one is just census, and like, that just means how many people you have at a given hospital as your inpatients, all those patients that you took in, how many on a given day. So you often will know like how many beds are in use. Um, can you continue to take admissions? Can you continue to take people in the ED? All that. But that term census is thrown around, and again, the most basic way to understand it is the amount of people in a hospital bed on a given day.
Yeah, great. And then hospitalist is a
Yeah.
term that, again, if you have to kind of know a little bit about healthcare, but if
Yeah.
you're not, what the heck is a hospitalist?
Well, and it's kind of a new position in terms of, I think, maybe about 10 years ago, this started really being a thing. And this is where a doctor, they just practice at the hospital. That's all they do. So, way back when you and I are kids and older than that, but, if you needed healthcare and you were admitted to the hospital, your primary care doctor would come see you. Like they would check in on you and say, like, how's this person doing? They might even adjust your medications, things like that. But then I think, 10, 15 years ago, we really started to see this practice of that's not a very efficient system. Not everyone's doctor can come, again. So wouldn't there be value in having a specialty where you just practice as a hospitalist? You're just rounding with patients, seeing how they're doing, helping coordinate care, things like that. And so this profession of being a hospitalist, and then there's various subspecialties and things like that. But just that's a doctor who they just almost exclusively practice in the hospital. But it's just kind of a different concept. And again, unless you were in the hospital, I don't think you'd ever even know that position exists. You would be in a bed recovering, and someone would come around on you and talk to you, and that's the hospitalist.
Wow, very good.
Yeah.
And you wanted to talk about length of stay again.
I just think it's just, to me, it's the most misunderstood thing, especially for anyone getting up to speed, especially for the general public. It's just the fact that we want to get patients out of the hospital as soon as it's safe, because honestly, their recovery goes better when they can be in an environment that they're more comfortable with. So I think that's why you've seen over time, what can we do in the home? What kind of services and monitoring and care can we deliver in a person's home? Because, 9 times out of 10, that's where they're going to recover better. So I just think for anyone, again, getting used to our industry, think about that fact that yes, we want to bring in people to the hospital when they need it, but we want to get them out as soon as we can, and we want to reduce that length of stay. And it just kind of goes against everything I think that a marketer would think of, which is you get someone in for a service, you really want to keep them as long as possible, but that's just not the case with their hospitals.
Yeah, and that's great. That's why I think as a patient, you're hoping that's the case, right? Like, get me out of
Yeah.
the
Who,
hospital.
who wants to stay at the hospital longer than they need to? Nobody.
Yeah, it's just, yeah. I love when I'm talking to people not in healthcare and they're like, hospitals, there's nothing good about what happens in a hospital. I was like, well, actually there is, but
Yeah.
it's like there's a fear factor, I think, that's out there for sure. So,
Well, I
you
was,
bet. Go ahead.
I was just going to say, I walked in a hospital many times, and I often think about that. It is true to some degree. There's a lot of things going on there that people are scared about, nervous about, but there's also positives. There's people who are delivering babies. There's people who are getting, health conditions taken care of that really are hurting their quality of life. So it's a hard one, like again, but every time I walk in a hospital, I kind of do it with that respect that most of the people in here as patients and family members, they don't want to be here. It's a tough experience. So like, how do we make it better for them?
Yeah, for sure. And I have a friend and colleague who just went through a heart attack, and like, it was like his experience was um, just wow. We forget. I think it's a little easy to get jaded about like the stakes, but somebody going through a heart attack from their
Oh
point
yeah.
of view, like, holy cow,
Yeah.
that's a scary experience for sure. But also very grateful to his doctors that hung in there with him throughout that because it wasn't apparently very easy.
Oh,
So
yeah.
the life and death, after a while you get so used to it because we live this every day. But then like, wait a minute, this is a big deal. So
It
let's
is.
talk. Yeah, for
You
sure.
know, yeah, one other just quick thought. I mean, I think, for anyone who works in a healthcare organization, like even if you're not based there, because not all that many people are based on the hospital campus today, get there once in a while, walk around, go visit people, take some tours, meet people. It's one of the best things you can do to orient yourself if you're new to healthcare. If you have a partner, even if you're working with a partner, see if you can go visit a facility. That goes a long way to understanding.
For sure. I totally agree. And if you're not, that's something that's not possible for you. I haven't seen it lately, but the Cleveland Clinic empathy video is
Oh
amazing.
yeah. Yeah.
That's just magical the way they put that together.
Yep.
Um, so you mentioned there's some funny terms on your list. So I'd like to hear a couple of your funny terms.
Yeah, two that really stand out to me. I remember I was reading a memo one time and someone talked about having a meeting at the MOB, and I was like, and it was one word, so it said mob, and I said, what in the world is that? And it means medical office building. This is the most boring terminology, but medical office building generally refers to like it's a standalone building on a hospital campus. Maybe that's where their doctor's office is. But it's one of those things where I read it and I was like, I have no idea what this means. What is a mob, and what does it have to do with healthcare?
Awesome. What was the other one that you wanted to talk about?
Yeah. So this one is really one of those terms. It struck me too. It talks about elope. If you ever hear the term elope in terms of a hospital, it does not mean generally that two people decided to get married on the fly and they left and it was a great thing. That's what people usually think with elope. People run off and get married. But in a hospital, it means that a patient has an unauthorized departure. Someone has actually left when they weren't discharged from the hospital. It can be a very serious thing. A lot of times those people need additional care, or maybe we're trying to transfer them somewhere. So if you see an elope, ever see an elopement at a hospital, it's a very serious thing. But it's so funny in my mind because that word is so opposite of what we would associate the term with elope in, just general lives.
Yeah, for sure. Like that's not a good thing. Somebody walks out and they could die like on the way out the door and
Or
who knows where they are.
Yeah, and just for the very practical purposes, when we discharge someone from the hospital, even if they're not in danger, we want them to know where they can get their follow-up care. We want them to know they're okay, that they got discharged to someone who can help them get home, whatever. So, again, it's just for very practical purposes. It can be, not just dangerous, but just kind of we need to know who's here and we've got a bed free and all that. So I've only seen, I think, this term used maybe once or twice in my career, but the first time I saw it, I really was like, what in the world does that mean?
So, there's a lot, obviously. And I mentioned I did a whole hour with my team on stuff that's too deep for this meeting here. But, how do people get up to speed faster on terms that really impact the field they serve?
Yeah. Well, I think there's a few things. One is just as you're new to the industry, don't be afraid to ask. I think, people tend to be shy. They don't want to ask about terms they don't understand. I really think you should feel empowered to ask. I like your suggestion too of, like again, there's tools like AI and ChatGPT, and even like just Google search with Gemini, like put those terms in, see what it comes up with. But again, that'll kind of explain it. But I think having conversations with people who really know it is super important. Obviously, they can look at the guide I put together too. I think that's helpful for some of the most common terms. And then I would also reiterate again, just take those opportunities to get more ingrained in the operations of their hospitals, your clinics, whatever. I'll tell you, anyone can get a tour of a hospital. Every hospital has tours. They'll either do it from someone who works there or a volunteer or whatever. Go in, see how it works, ask questions. You'll learn so much that way. That kind of immersion really speeds up your learning curve.
That's great. Yeah, the AI is interesting. There's a lot of terms in healthcare that can get really confusing, like a hospital foundation. Well, there's different kinds of hospital foundations with different purposes, or what's an IPA, or how does that differ from a medical group? And from an outsider's perspective, it can be really challenging to understand.
Yeah, I absolutely. I feel like I learn things all the time. Again, like as long as I've been doing this work, you always learn something new, and there's always some new terminology that's thrown out. So it is kind of a lifelong learning experience, but I think there are some ways to accelerate it, and AI is a great option.
So one question we didn't hadn't talked about offline, but I'm just curious, as a communications officer now, educating the public is a big part of what you do. Anything else that you think is, beyond the terminology we just discussed, but other things that you just wish the public knew, public or marketers knew better?
Well, I would say that one thing that is helpful in this age of sort of disinformation is just like really being careful with the sources of where you're getting information. Relying on your trusted health systems, your physicians, your public health departments. That's where you should really rely on information. I think it's really easy to get caught up on misunderstandings on social media and other places where there's just a lot flying at you. So I think one of the biggest things, just understand what we do, is follow and engage with trusted sources. I think that's something that's super important right now.
Yeah, for sure. Well, Alan, it was fun to have you back. It's been a while. We'll have you back again soon. And thanks for all the work you do and the leadership you take in our field. So I appreciate
Yeah.
your time today.
Thank you, sir. It was fun.
All right, great.